Did everybody have a good day so far? Excellent. Well, thank you all for coming, and thank you so much for staying to the end. And hopefully we can provide some additional value here. We have a panel of experts up behind me. And I'm Dr. Benjamin Walter, one of the movement disorders neurologists here in section head. And I'll just introduce everybody here. Susan Light from Occupational Therapy. Ted Weissfeld, one of our movement disorders neurologists here in the Akron area as well. Darlene Floden from Neuropsychology. Shannon Shaffer, who's one of our advanced nurse practitioners and does a lot with DBS programming. And Taylor Rush, one of our psychologists in the Center for Neurological Restoration. So with that, I'll start with the first question. And we have somebody floating through the audience with a microphone too, so that we can take some questions directly from you. I don't know, we don't have enough of these question cards still left over. I like this question. The question is, does the medicine for PD cause hair thinning? And somehow, I don't know why they handed this to me, but I can answer that question, and then we'll save the other ones for the panel. Yes, in the sense that any medication probably can. Generally, I would say they typically don't, but a lot of medications can have hair thinning as a side effect. There's a lot of other things that can do that, nutritional deficiencies, thyroid function, and otherwise. So it's good to kind of figure out the timing of it. But I wouldn't say that's a major problem that we typically see, but I have seen it in a couple patients where it seemed to correlate with the starting of the medication. And then we can always switch medications because we do have a lot of different medications with different ingredients that we can use. Okay, let's get some for our panel. This one will be for Dr. Weissfeld. Will you please address how effective Botox is for Parkinson's patients?
Hello? Oh, yeah. So Botox can definitely be used for Parkinson's patients. Typically, it would be used for patients who have dystonia. So that would often be like a painful turning in of the foot or hand, cramping up of the hand. So for patients who have that either doesn't respond to the oral medications, which can also help, then you can use Botox for that. The other reason we might use Botox is for drooling, sialuria. So we can use botulinum toxin injections into the salivary glands to reduce drooling. So those would be the two reasons we would use it. And they can be very helpful for those.
Great, and that's usually done every 3 months for those who get it, and I think certainly many of our patients get those treatments, but not directly for the other Parkinson's symptoms. It's for some of those other things that are common with Parkinson's disease. All right. Here's a good question. The question is, how much is, I think Dr. Mata's back there. How much is known about the various genetic subtypes of Parkinson's and how they progress? Is it really helpful to have genetic testing, which was the topic of in part of Dr. Mata's talk earlier. I think this will. I will mention that the talks today should be available later, pre-recorded. We hope to have a rebroadcast of Empower You as a virtual event. So if you missed Dr. Mata's talk, I would definitely recommend hearing it. I think we still have a lot to learn about the genetic subtypes of Parkinson's disease. I don't know, Ted, do you have any thoughts about that?
Yeah. I think a lot of the genetics of it is right now definitely a little unknown in terms of how they might differ from one another. The genetics often have a little bit earlier age of onset, so I think that's one of the big things is that people with certain mutations may present sooner with their symptoms. They also present a unique approach, potential for treatments in the future. So a lot of the research is focused on kind of targeting each of these genetic subtypes. But in terms of their like clinical symptoms, they often are indistinguishable from one another. So I think most of my patients who, particularly at older age, I typically don't suggest getting genetic testing just because it won't have a major impact at a present time on the treatment approach or what we do for those patients. So in very young patients, we tend to be a little bit more interested in doing genetic testing just because of the likelihood that there may be a mutation. But in the grand scheme of things, it doesn't greatly alter the care.
And there was a big study sponsored by the Parkinson's Foundation called PD Generation that we've recently been finishing up that some of you may have participated in. And now Dr. Mata has a registry for genetics that we're doing, I think mostly at our main campus. But if you are interested in that, let your provider at the Cleveland Clinic know or let one of us know. And we can refer you for that because we're collecting genetic information and trying to get all that tested to help get a better understanding of the different symptoms, I believe, as they progress. And Dr. Mott is still back there, so maybe you'll get a chance to ask him in a little bit. Any questions from the audience? We've got a microphone here. I've got more questions here, but if there's any live questions, if you put your hand up, we can have somebody come to you. There's a question right here.
Sorry, this is on. If I just hand it to you, you want to ask it?
Okay. My wife has recently had a dental appointment, and there's been some issues with her teeth, and the dentist said that Parkinson's can cause dental issues. Can anyone address that?
It's a good question.
Thank you.
Some thoughts? I have some thoughts. You have some thoughts? Sure, I'll answer that. I think the issue there might be with a dry mouth. When you have your mouth can be open with Parkinson's, and even if there's drooling, a lot of people with Parkinson's do have a dry mouth that dries out easily. And when your mouth is dry, your gums and your teeth tend to have more problems. And so I think that's what that is typically related to, why they might be mentioning that. The dentists do have some treatments they can give you with a kind of artificial saliva to help keep your mouth moist. And it's a matter of balancing that with drooling problems, which again, we have the mention of botulinum toxin that was just mentioned, and some other treatments with medications that can help with that. But it is a challenge sometimes. Here's a question for Taylor, our psychologist. So much refers to tell your family or caregivers. Is anybody trying to work on resources for PD patients who live alone?
Yeah, so that's a great question. I think quite relevant for a number of our patients that we see. And I know that the Parkinson's Foundation actually offers some specific education and resources to individuals who are living alone with Parkinson's. And I believe that's actually even what some of their resources is entitled, is Living Alone with Parkinson's. And in addition, in our center, we have several social workers who help people get connected to resources that they need within their own community. So whether that's home health care or transportation or other things, if you are a patient connected with us, please just let your provider know that you would like a consultation with social work, and we can look into what resources we can get you linked into locally.
And I'll just add to that and point out that in the Center for Neurological Restoration, we have a tremendous resource of 2 full-time social workers in our area specific for our Parkinson's patients and other related movement disorders. I'd say that's a fairly unusual resource. We're very happy that the Cleveland Clinic has supported us to have those resources with us to help our patients, and they are invaluable. So if you have social work needs, and you get your care at the Cleveland Clinic with us, definitely reach out to your provider and ask them for that, because we can put in a consult and they will call you and they will go over all of your issues. And there's a really broad area of things that they will treat. I think it's really fantastic that we have that. Here's a question for therapy. The question is, what is LSVT big?
All right.
Susan.
So LSVT big, it was actually one of the originating for all the exercises that you kind of saw today with the different groups. LSVT is Lee Silverstein. It actually initially started with Loud. The big program was an off-swing. It is actually for occupational therapists and physical therapists, and it is movement-based. So you hear big, that's what we want to see. It is a program, it is fairly intensive, but we've seen the best results with it. It is 60 minutes, 4 days a week for 4 weeks. And then normally after our clients have finished that program, we'll see them in about 6 months and just see how they're doing. So we normally do a checkup with them as well. But no, pretty intensive program, but really nice results for the exercise and changing movement patterns.
Yes, here's a question in the audience.
Where is LSVT big done?
Where is it done? All right, so in our Akron area, we have our Lakemore site. Actually, Shanda is one of our big therapists. I am one of the other ones. I am at White Pond. Those are so Lakemore and White Pond, I guess, are the main 2 areas, aren't they?
Yeah. If you're not in the Akron area, you can also search on the LSVT Big website. You just go on there and it asks where you live, and it pulls up all of the LSVT clinicians that have chosen to list themselves on the site. So that's a good way to locate them.
But if you don't think you can do the big program, there is another one that Cleveland Clinic offers, and it's PWR, which is Parkinson's Wellness and Recovery. And they have that at the Mellon Center. I also do PWR at White Pond. And so we, at our Lakemore site and our Stowe site, they also do PWR. So there are other programs out there if you can't do the big.
Excellent, thank you. Here's a question about clinical trials. Maybe Shannon can answer this for us. The question is there some sort of national clearinghouse or information center that gives information on all national or international clinical trials?
Well, this is kind of easy because I just sat through the research talk. But you can go to clinicaltrials.gov. You put in Parkinson's disease, and it will bring up all of the active phase 1, 2, and 3 clinical trials for Parkinson's. Another good one is FoxFinder. If you just put that into your Google search bar, it'll pop up. And those are the studies that they've compiled on the Michael J. Fox website. So I usually suggest those 2 are the first best places to start. Those are the ones that are actively enrolling. They also have a list of ones that might have closed if someone told you about a study and you wanted to see if you could get into it. So those are the 2 best ones to start.
Very good. This next question has to do with slowing the progression of Parkinson's and treatment of other problems like memory. And I'm going to ask our neuropsychologist, and I'll chime in, but it's really the question, are there any studies showing value of supplemental oxygen for memory or cognitive issues or other issues that we're aware of?
Not to my knowledge. That said, if you need oxygen at night because you have obstructive sleep apnea, you should be using that. So if they've given you a CPAP machine or BiPAP machine that you hate to use, go talk to them about how else to try and use it. Because if you're not getting as much oxygen as you should be getting, that's going to go straight to your memory.
And I think there's a lot of data on sleep apnea, as you mentioned, and problems with cognition, correct? So that's an understood phenomenon. But there's a lot of oxygen in the air. There should be enough for you and for all of us if your lungs are working well. So supplemental oxygen shouldn't really be necessary. And I'm not aware either of any use that's shown data that's supporting that for Parkinson's disease. And if you have questions like that and you wonder, I think what Shannon Shaffer just mentioned is a good place to look at clinicaltrials.gov if you're looking for a clinical trial, if they have any studies that have looked at something, and you may be able to see if there's anything that's being looked into it, but currently that's not something that we see a major use for. Any other questions in the audience? There's one right over here.
The Parkinson's Foundation talks about building your team. Does that really mean people, doctors, talking to each other? Because so far I haven't found that. And I'm wondering if the Cleveland Clinic does that.
It's a very good question. I can tell you as our section head that we practice as a team. So naturally in our group, we have a lot of people with different disciplines that approach you from different angles and help with different aspects of Parkinson's. And we regularly communicate every day with each other and our patients. It's the unique idea of having care centers focused around different disease states regardless of the discipline, as opposed to the more traditional way that hospital and healthcare systems are set up, where you have people of a similar discipline that work together that treat many, many different patient types, but it's not really focused on the patient or the kind of care. So that's kind of unique about our center and institute model. And I'd also say that within the Cleveland Clinic, some of our phones were buzzing earlier because one of our colleagues was seeing a patient in the hospital and had a question that related to movement disorder. So he was sending a chat message through our electronic medical record to about half the people on this panel, which I'm not sure if we answered yet because we're all here, but somebody was getting back to him. But that kind of communication is facilitated through the electronic record that we use at the clinic, which is very robust. And then in addition to that, we have a lot of people on our team that are on your team. And when they say that, I'll just let maybe Shannon talk a little bit about what is talked about, because I know we talk about this a lot, and about building your team and what else that means maybe beyond the team that we already have pre-built for you.
So, and to answer your question about like, do we do that here at the Cleveland Clinic? I absolutely reach out to many of my patients' primary care doctors. I reach out to specialists. I just yesterday sent out a message to a cardiologist saying, I wanted to prescribe this medication, but the patient has AFib. Are you okay with it? She got back to me within 2 hours and was like, no. So it's super important because then it took me down a different path. So, but on top of that, something else that we do at the Cleveland Clinic that we're trying to get to do bigger is Dr. Walter and I started an inpatient program at the main campus of the Cleveland Clinic. And the importance of that is something I don't know that anyone touched on any of their talks, but we can get you as good as we can while you're at home and in your community. But you could go in and have a hospitalization that can really knock you back if something doesn't go right with your treatment of your Parkinson's. So at the main campus of the Cleveland Clinic, myself and one of my colleagues actually are alerted to every single Parkinson's patient that's in the hospital for whatever reason. And if we actually it's kind of like a big brother thing where we'll just make sure all your meds are correct. We'll make sure that they're scheduled for the appropriate times. We also make sure you don't get any contraindicated medications, which can be a big deal when you're in the hospital. And then we actually go through what's going on while you're there, and we make sure you're not having any specific problems that we can help with. We hope to eventually get this at all of the Cleveland Clinic locations, but right now we are only actively able to go to the patients in the main campus of the Cleveland Clinic. So always let your doctor know if you're going to have a planned surgery or a planned hospitalization, because then we can get the heads up to look out for you. So that's a huge thing that we have that I don't know that any other hospital has in the country right now, because I think we're the first. So.
And I think that's a super excellent question, and maybe I'll take advantage of it to highlight the answer to your question with the rest of the panel here. So Taylor Rush, who's our psychologist here, can you tell us what it's like to work with the team and how you participate as a psychologist, as one of the team members taking care of our people with Parkinson's?
So I would say, as part of my training as a health psychologist, we only ever work in medical settings, really, and throughout our entirety of training. So I've worked in multiple inpatient and outpatient hospital settings. And honestly, it wasn't until I got here in the clinic, in our department, that I felt like an equal. Because in many ways, psychology was like, oh yeah, you're a doctor, but not really. And so now I feel respected and I feel like people understand my role. And some of that was me kind of digging in like a tick and saying, you're not getting rid of me. And so it kind of, worked. But I love being able to work alongside neurologists and advanced practice providers and PT and OT and speech, because I feel like I'm my most effective when I'm part of a team. And so for me, it's kind of my dream job. And so I love that we've been able to grow as a department with all these different specialties. And I've been able to grow our behavioral service to where we now have 2 psychologists and 2 social workers, and we're growing our psychiatry service so that we can offer all of our patients the services that they need and deserve.
And then I'll continue with that. Dr. Floden, who's here with as one of our neuropsychologists, what's it like to work as part of the team, specifically with regards, I think, to the Deep Brain Stimulation Conference, and then also interacting with our other providers? Do we communicate, around our patients to help their problems from all angles? And certainly you're dealing with the cognitive ones.
Right. So particularly with Parkinson's disease, the motor symptoms can kind of be front and center because these are things people can see. And so this is really where the focus comes in. So the cognitive things that people will often notice and are as important can sometimes be orphaned kind of off on their own. Working in a team, being, kind of right next door to the neurologist, we're all in a room discussing every patient and the in and out and what's going to be the best. Those conversations include cognition. And if you're not part of a team, you can't do that. This is just kind of one piece of information hidden in your chart that never, doesn't have any relevance. So being embedded in a group of other professionals and everyone's focus is on that one patient is, it's ideal. It's the way to do things.
And then Dr. Weissfeld here is a little bit unique in that he's also a movement disorders trained neurologist like myself, but he's got the farthest reach down south than all of us in that he's got clinics deep into Akron, which I'm sure a lot of people here may be from since we're in Akron today. And we have other more specialized care at the main campus for sicker patients. We've got our deep brain stimulation program. But what's your interaction and how do you extend the team to Akron if, say, a patient who might have a provider at main campus gets admitted to the hospital, you end up seeing there as a communication, what's that like? And then also if you need to lean on some of the expertise at the main campus, how do you extend the team geographically down here to Akron?
Yeah, definitely. So I'm from Akron, so that's why I chose to train to work here, and so trying to provide the care that was not necessarily here before I got here. With Parkinson's patients, a lot of it, if things are super straightforward, we don't necessarily need to kind of lean on the care that can be achieved up in Cleveland. For super complicated patients, I know that I've shared a couple patients with Dr. Walter or patients from Cleveland who, maybe later in their disease course are starting to have a hard time going from somewhere in the South region up to Cleveland. A lot of patients will end up transferring their care from Cleveland to myself down here just for convenience sake. But, I still will participate in the surgical conference when patients down here need surgical treatment. We can certainly kind of refer you to there. And all the time, patients who are from movement disorder clinic up in Cleveland are getting admitted to Akron General. I end up seeing them. I work in the hospital there quite often. And so, those patients who there is a movement question, I'm getting asked all the time. And kind of, the doctors who are in the hospital at Akron General for neurology are sometimes coming from Cleveland, so sometimes they have a little bit of more exposure to movement patients, but sometimes they don't feel that comfortable with it, and so they'll call me and I can assist in the care for those patients.
Excellent. And then finally, Susan Light, as a member of the occupational therapy team and therapy in general, can you tell us how we all interact as professionals in extending the team around patients and their specific problems to address occupational or hand issues or therapy in general?
Well, I'm kind of lucky because, so I've been working for 21 years. And so, where we work, like I have a speech therapist there, I have physical therapists there, I have occupational therapists there, and we're able to throw ideas off of each other, particularly for actually any clientele we get, but very specifically, our Parkinson's. But then the other nice thing is now, since we have all these specialists, now, I mean, it's very easy contact. Like, I think I messaged you one time, and it was like 20 minutes, and I got a response back on one of the concerns I had with one of my clients. And so, you know, the more that we have the specialists out there, you know, we are all connected. So, which is really, really nice. I think it adds to the care and the quality that we get out of our clients. So I think it's very important.
Excellent. So did we answer your question?
I have all these other doctors who are not from the Cleveland Clinic that are from my area. And I'm wondering, how the heck do they ever connect? They don't seem to,
Yeah.
including my general practitioner, who I love, but who said, you know, I'll leave it, the experts, your cardiologist will take care of that, your neurologist will take care of that. So it's so confusing.
Sure. And we have, and there may be still some folks here from out of state. Obviously, there may not be a local Cleveland Clinic branch in your state, but we do certainly work with specialists and doctors, you know, locally in other areas. And as a patient, I think it's good to advocate for yourself, or as a spouse for your loved one, to make sure you have all those resources around. Increasingly, some of the electronic health records are becoming better at sharing information across systems. So that helps us communicate. Certainly letters go back and forth. But you know, it's certainly good to advocate for yourself and bring information back and forth, and make sure that the doctors know who the other specialists are as part of your team, so they can add it to your record and communicate with them, because at times that becomes critically important. But it's great that we're finishing up with a question about teams, because I think that that is certainly a forte, and I think something that's very important in the care of people with Parkinson's. And we'll take any other questions you have offline. I think a few of us will be around still. But thank you guys very much, and have a good night.